some of this information. This is one of those areas where you want to use flashcards or something to remember these. But what I'll say overall is if you can classify this information and understand what these cytokines are doing in terms of communication, it makes the mechanisms a lot easier. And so we'll start with the pro-inflammatory cytokines just because we've talked so much now about the acute inflammatory response. It's going to make for an easy transition. And then we'll talk about some additional cytokines, some things that we haven't quite talked about as much yet. Going on to that, we'll talk about pro-inflammatory cytokines, like we said first. And when you're thinking of cytokines, what are we talking about? We're talking about, if you have two cells here, right? You got an antigen presenting cell, you got a naive T cell. Essentially, we're saying, what do these two cells use to communicate? And what they use is cytokines, right? So one cell can release molecules to tell a dendritic cell to do one thing or the other. And you can see different cytokines can cause different types of responses and can cause, this dendritic cell to essentially behave differently. Okay, and so that's what cytokines are doing. They're communicating between cells. Okay, so again, when we categorize this in terms of what these cytokines are doing, I like to start with the acute inflammatory response, just because this is where it all starts. This is what we keep talking about, is this acute inflammatory response. Remember, how does this happen? And again, I'm going to go through this fast because we've talked about this, probably in 3 of these videos already. So go back, check the other videos out if you're not familiar with this. But again, pattern recognition receptors are going to bind to these non-specific pathogen-associated molecular patterns or damage-associated molecular patterns, right? Things like LPS, for example, binding to toll-like receptors, or the damage-associated molecular patterns. Cells that are infected with a virally infected cell, for example, that is releasing its cell contents, those contents binding to these pattern recognition receptors. This is going to set off a non-specific innate immunity cascade increasing NF-κB. NF-κB is going to lead to the downstream transcription of interleukin-1, interleukin-6, TNF-alpha, leading to production of acute phase reactants and increases in temperature set point, or we can just say increase in fever, okay? And also an increase in expression of endothelial adhesion molecules, right? We've talked about this in great detail in the last video. What's the point of that? Well, let's say you have an infection somewhere, right? You want neutrophils to get to the site of that infection. You want them to get to the site of inflammation. And to do that, you need to put endothelial adhesion molecules on those endothelial cells. So when the neutrophils come in rolling, they're going to bind really tightly to those endothelial cells and get in through diapedesis to the site of infection. And again, we talked about all of that in the last couple of videos, but it's essentially this process that causes that, right? Interleukin-1, interleukin-6, TNF-alpha. So if there's nothing else that you want to remember from this first category, if there's only one thing you can remember, it's definitely going to be this. And you're going to remember neutrophil chemotaxis is largely driven by interleukin-8, LTB4, C5a. And again, we've talked about all of this multiple times in the last few videos. But again, these are the communication pieces that the body is using to, number 1, increase temperature set point, set off an acute inflammatory cascade, and then number 2, allow neutrophils to taxi to the location of an infection. The thing that we haven't talked about as much is going to be the proliferative response. And when you're thinking about the proliferative response, I've got the innate response down, right? We got innate immunity. But what about my immune cells? What about my T cells? What about my B cells? What about my natural killer cells? That's going to be this proliferative response. We want those cells in the party too, right? Because they're ultimately going to help build memory responses, cell-mediated responses, humoral immunity, right? And so to do that, the number 1 cytokine you need to remember is interleukin-2. So let's just say that we have some cell here, okay? We're just going to take an example here. Let's just say that we have a T cell here. Now let's just say that it's a naive T cell. Now you've heard this term before, right? You've seen it here too. What is a naive T cell? Naive essentially means that this T cell has not kind of run into its antigen yet. So if I were to draw a T cell receptor on here, maybe I have a unique structure here, okay? So this cell's T cell receptor, TCR, okay? So this T cell has a T cell receptor, and it's got some other receptors out here too. Let's just say it has another receptor here. This will be its interleukin-2 receptor, and you'll see where I'm going with this in a second. So what will happen is, at some point, this T cell has a very unique T cell receptor, and it might even have some neighbors here, okay? But this T cell has a different T cell receptor, okay? But it does have the same interleukin-2 receptor. So that's kind of its neighbor cell, and then maybe it has another neighbor cell on this side. Another T cell here, again, unique T cell receptor, okay? So there's a T cell receptor, but then it also has that same interleukin-2 receptor. Eventually, what can happen is, let's just say that there is some dendritic cell, okay, or some antigen-presenting cell, and that antigen-presenting cell, right, so this is my dendritic cell, okay, this dendritic cell is going to eventually, maybe it runs into a bacteria or some pathogen, right? And so that dendritic cell is then going to take that pathogen and it's going to display an antigen, right? A component of that pathogen on this MHC receptor. So let's just say that this is the antigen. Okay, so it's displaying out on this MHC receptor. Now, if this dendritic cell presents the right fit for that antigen to the right fit for that T cell receptor, if these two can bind and lock in, and let's just say that these two are a perfect match, this T cell will then become activated. Okay, so it will go from naive to activated. So that antigen that fits nicely into that T cell receptor. And again, this antigen, if it binds here, it might not fit nicely. It might not fit nicely at this T cell. Okay, it's going to bind to a very unique arrangement of a T cell receptor. Now, what will happen is once this T cell gets activated, it says, okay, hey, look, there's a problem here, right? There's a potential pathogen present. And so what this T cell will do is it can start to release interleukin 2. Interleukin 2 is going to allow for increased proliferation of immune cells. T cells will have increased proliferation. B cells will have increased proliferation. Natural killer cells as well. Now, it does this in a few ways. One of the classic things that sometimes gets asked about for interleukin 2 is that it has autocrine action. Now, let's just talk about that for a second. Let's start with something that we already know. Okay, let's just say way off, let's just say away from these cells here, there's a lymph node. Okay, there's a lymph node. And inside that lymph node, maybe we have another T cell. Okay, maybe we have another T cell inside of this lymph node. I'm going to put LN down here for lymph node. And to get into that lymph node, maybe there's an afferent arteriole over here. Okay, so you got to get into the bloodstream to get into that lymph node. Now, maybe this interleukin 2 can travel through the bloodstream, right? It can travel through the bloodstream all the way to this lymph node to eventually bind to this T cell's interleukin 2 receptor. That would be an example of endocrine action. Okay, and so that's what we talk about when we talk about the endocrine system. We're talking about hormones that are traveling in the blood to get to a distant site. That's what endocrine is. If we talk about paracrine action, okay, so paracrine would be if this interleukin 2 that this activated T cell released, maybe it bound to this interleukin 2 receptor, or maybe it bound to the interleukin 2 receptor over here at the neighboring cells, the cells around this T cell. That would be an example of paracrine action. Okay, so that's paracrine. Now, if this interleukin 2 went and maybe it bound to the same cell that released it, okay? So in other words, this activated T cell is releasing interleukin 2 that is then binding to the cell that released it. That would be an example of autocrine action. Okay, so I know that can be a little confusing, but the classic thing to remember when you think about autocrine action is interleukin 2 is the one that usually is going to get asked about in relation to autocrine action. Now, interleukin 3, okay, remember in the very beginning, the series when we talked about, okay, this is kind of the lymphoid lineage, your myeloid lineage. When you're thinking about interleukin 3 in general, just high level, you're usually talking more about, stimulating the bone marrow to release some of those cell lines that we're going to talk more about in hematology. Okay, so I think of interleukin 2 more in immunology. I think about interleukin 3 more in hematology. Okay, so we'll make more distinction on that as we go into hemonc. But that's kind of my way of thinking about it. It's going to increase hematopoiesis. This is your acute inflammatory response, more of the innate response, proliferative response. Now we're starting to ramp up into a specific T helper response, which we'll go into next. So let's just start touching a little bit on this T helper 1 response. And we actually talked about this quite a bit when we talked about things like granulomas. The T helper 1 response is going to be very closely linked to a cell-mediated immune response. And we're going to talk about this in great detail when we talk about the T cells. But in general, you want to think about kind of your end game here is CD8 positive T cells and natural killer cells. Okay, so that's where this is kind of headed, okay, this whole process, and you'll see what I mean. So let's just say, if we wanted to just explain this a little bit, let's just say that we have some antigen presenting cell here, okay? Let's just say that it's a macrophage. I'm just going to write MO here for macrophage, and it's going to have interacted with some pathogen. It's going to present that pathogen on an MHC receptor. Now remember, there's two types of MHC. There's going to be MHC1 and MHC2. Remember, MHC1 is going to bind to CD8 positive T cells. Remember your rule of 8s. 1 times 8 is 8. So MHC1 binds to CD8 positive T cells. But for the sake of this example, we're going to say this is MHC2, which means that the antigen on here is going to bind to a CD4 positive T cell. Okay, so here's my antigen. Okay, and so there's my macrophage. So it's interacted, maybe it phagocytosed some bacteria, for example, and now it's presenting that component, that antigen, to a T cell. Okay, and let's just say that over here I have my T cell. Okay, so I have my T cell, it's CD4 positive, and it's naive. It hasn't interacted with an antigen that meets the criteria for this antigen receptor. Okay, so let's just say that this T cell receptor fits nicely with this antigen, right? And let's just say that this antigen binds to this T cell receptor. Okay, so in that case, if these were to bind, this T cell, like we just said, would then become activated. Okay, so then this T cell would be activated. It would no longer be naive. Okay, so we'll cross out naive, now it's activated. Now after this binding happens and this starts to get activated, the macrophage is going to release some cytokines, okay, some cytokines over to the T cell. In particular, we're going to release interleukin 12, okay, and that's what you can see here. So once this macrophage presents the antigen to this T cell, it's going to release interleukin 12. Okay, and that interleukin 12 is going to help stimulate this T cell to become a T helper 1 cell. Okay, a T helper 1 cell, which is going to take us into this T helper 1 response. Now you have a T helper 1 cell, and it's going to say, hey, right back at you, macrophage. It's going to send interferon gamma going the other way. Okay, so now this T cell is going to send interferon gamma back to the macrophage. Okay, and we'll talk about what this is in just a second. Okay, so the interferon gamma is going to stimulate the macrophage and activate the macrophage. Okay, so you're going to get some macrophage activation too from this interferon gamma. You know what, I'll do this in pink just to keep my colors consistent here. Okay, so this macrophage is going to get activated now because we sent some interferon gamma its way. Okay, I'm going to put an A here for activated. And it can also send some of this interferon gamma to the CD8 positive T cells. I always think of them as the scary cytotoxic T cells. Okay, so these are the really scary, mean cytotoxic T cells. We're CD8 positive T cells. And it's going to send some interferon gamma to them too. And that's also going to activate these CD8 positive T cells as well. And so that's essentially what's happening. So just to recap this really quickly, the macrophage had an antigen that was bound to its MHC2 protein that fit to this T cell receptor on this specific T cell, and then that macrophage released interleukin 12 to turn this T cell into a T helper 1 cell. This T helper 1 cell then released interferon gamma back to the macrophage, activated the macrophage, and also some of this interferon gamma could potentially reach some of these cytotoxic CD8 positive T cells to also look for this pathogen. Okay, so that's this whole process. And remember, there's also other things happening. You might say, like what? The other thing happening is interleukin 2, right? We already talked about interleukin 2 can also be released as a general proliferative response for all immune cells. It's not as specific to T helper 1 or T helper 2 response. Okay, but this is the process for the T helper 1 response. And where did you see this response already? Well, you saw this response when we talked about granulomas. It's very classic to see this T helper 1 cell-mediated response for granulomas because you have all these macrophages getting activated, turning into epithelioid cells, and then eventually giant cells. Okay, and you have all this interleukin 12 that's essentially sustaining this granuloma. And you can kind of see that up here. So if you look, interleukin 12, right, being released from the dendritic cell to the naive T cell. Remember, these are our communication lines. This interleukin 12 can then cause your T cell, your naive T cell, to form a T helper 1 cell that then releases interferon gamma. So that's the T helper 1 response. If you got that down, if you know where these factors fit, right, you can make sense of a lot of these different processes. It's not as complicated as it looks. And again, it's the same thing here. You have the antigen presenting cell binding to a naive CD4 positive T cell, MHC2 binding to the T cell receptor. Okay, we'll talk about this in a future video, but essentially what's happening here is this connection is causing lines of communication to be sent from one cell to the other, right? Interleukin 12 and then interferon gamma going back the other way. Okay, that's what these polarizing cytokines are. They're very specific for the T helper 1 response. Now, the last thing I want to touch on here is going to be interferon alpha and beta. Interferon alpha and beta, think of them as kind of in this separate class from interferon gamma. These are going to be particularly important for managing viral infections. So the big thing that these two cytokines are going to do is they're going to allow for there to be an increased expression of MHC1. Now remember, MHC1 is on almost all of our cells. Okay, so cells that have nuclei are very classically going to have MHC1 on them. So it doesn't have to be an immune cell. It doesn't have to be a phagocyte or an antigen presenting cell. It can be almost any cell that has MHC1. And the whole point of that is, if there's something wrong with one of our cells that's not involved in the immune system, it will then potentially be presented on the MHC1 to mark that cell, to say, hey, there's something wrong with that cell. Let's destroy it now before a potential virus or cancer in that cell replicates, right, and then affects the cells around it or metastasizes. Okay, so that's the whole point of MHC1. It's a marker for each cell. Okay, so if you have all of your cells, right, you have essentially a receptor on there, and if there is something wrong, right, if a virus gets in, let's just say we have a virus here. Okay, we have some virus here. If this virus infects this cell, then this marker on the cell is going to tell us, hey, this virus infected this cell. And that marker, again, is MHC1. It's on all of these cells. Once we find out that there's something wrong with this MHC marker, then these CD8 positive T cells, remember, they are the ones that are binding to MHC1. They are going to go after that cell to destroy it before that virus can hijack the cell machinery and then affect all of the cells around it. Okay, so that's the point of MHC1 simply. And interferon alpha and interferon beta are the cytokines that are essentially upregulating the MHC1 exposure here. So they're putting more MHC1 receptors so that there's a higher likelihood that these cells will then present these viral antigens, right, so that they can more quickly be destroyed if infected. That's the point of interferon alpha and beta. So if there's a viral infection present, interferon alpha and interferon beta might be upregulated, especially locally here, to tell these cells, hey, upregulate your MHC1 receptors. There's a high risk of a virus around us, potentially. Okay, and so that's what they're doing. And also they have some other effects. They can also break down mRNA so that a virus that does infect a nearby cell can't hijack gene encoding processes to allow for viral replication. Okay, but that's the key here. Interferon alpha, interferon beta classically going to be used to kind of protect from viral infections. Again, interferon gamma in a whole different spectrum. Interferon gamma, we're talking mostly about things like T helper 1 response, granulomas, activation of macrophages. Now, when we go into the different deficiencies and diseases, if you just understand this process, you can make complete sense of this. For example, if you have a patient that has interleukin 12 receptor deficiency, okay, so the receptor that binds to interleukin 12 here, let's just say that it's not there for whatever reason. If you don't have interleukin 12 receptors, right, then when the macrophage tries to activate the T cell to make T helper 1 cells, it's not going to work because the CD4 positive T cell doesn't have a receptor for it. So to get around that, you can give the patients interferon gamma. You can bypass that step and just give the patient interferon gamma, and that will continue to protect patients from things like TB. If the patient did not receive interferon gamma, right, and they have an interleukin 12 receptor deficiency, right, you're never going to be able to have a good T helper 1 response. And so these patients will have higher risk for conditions that can predispose them to things like granulomas, right, which are maintained by interleukin 12, specifically mycobacteria, tuberculosis specifically being the big one. Okay, so that's just how you got to think about it. Conversely, if you have a patient that has an interferon gamma receptor deficiency, if you give them interferon gamma, it's not going to help the situation because the macrophages can still not get activated because they don't have the receptor. So in a situation like that, you might just want to treat the underlying infection. For example, if a patient has TB and they have interferon gamma receptor deficiency, you would just treat them more aggressively for TB using RIPE therapy, etc. Okay, so again, just making this big picture, that's how you think through these mechanisms. Okay, coming right off of the T helper 1 response, let's talk a little bit about the T helper 2 response. So remember, we have this initial starting point here where we have some antigen presenting cell presenting an antigen to a naive T cell, right? A cell that hasn't been exposed to this antigen before. And there's a lot of different ways we can go by communicating with that cell using different cytokines, for example, okay? And we already talked about, look, if we go down the T helper 1 pathway, that macrophage or that dendritic cell potentially will release interleukin 12, sending me down a T helper 1 pathway, which will ultimately result in interferon gamma being released from that T helper 1 cell to then activate that macrophage, activate CD8 positive T cells, and potentially natural killer cells. CD8 positive T cells, again, think cell-mediated immunity. You're going after cells to attack them, essentially going after cells that have MHC1 that are infected. Okay, so that's the process of interferon gamma. And remember, this interleukin 12 is very classic for stimulating this pathway to lead to macrophage activation, epithelioid macrophages, and giant cells in the setting of a granuloma. And we talked about that in great detail. So that's this first pathway that we just talked about. Now, if we look at interleukin 4 here, this is going to take us down the pathway of the T helper 2 pathway. Okay, and again, this is humoral mediated. When we say humoral mediated, what are we talking about? We're talking about primarily B cells, okay, and more specifically, we're talking about plasma cells. And remember what I said about plasma cells. Plasma cells are essentially like antibody factories. So high levels of antibodies is going to be pretty much associated with this humoral immunity. Okay? So you can see here, interleukin 4, interleukin 5, interleukin 9, interleukin 10, and interleukin 13 all going to be very classic for this pathway. You might be saying, well, why? Why are those cytokines so specific to the T helper 2 response? And it goes right into this next segment here. So remember, this dendritic cell is then going to send interleukin 4 over to this naive T cell, and in doing that, will stimulate this T cell to become a T helper 2 cell. That's step number 1. It's a CD4 positive T cell here, right? CD4 positive binding to this antigen presenting cells MHC2, right? Because antigen presenting cells usually are going to be using their MHC2 to express antigens to CD4 positive T cells, and then stimulating a cascade. 2 times 4 is 8. Remember your rule of 8s. So then this naive T cell is going to get stimulated with interleukin 4 to go down the T helper 2 pathway. T helper 2 cells will then go on to release specific cytokines. Okay, cytokines that include interleukin 4, interleukin 5, interleukin 13. And we're just going to say that we have some antigen presenting cell here. It's got MHC2. It's got an antigen on it. Remember, MHC2, it would have to be for it to bind to a T cell. And then let's just say that we have some T cell here. Okay, it's going to be a CD4 positive T cell. All right, and this T cell is going to be naive, right? It hasn't bound to its antigen, okay? And let's just say it has a T cell receptor right here, okay? And that T cell receptor just so happens to be a perfect fit for that antigen. So these two are going to bind, right? And then what's going to happen is this T cell will then get activated, okay? It will get activated. And when this T cell gets activated, now what can happen is the antigen presenting cell can send over a signal. We talked about in the T helper 1 response, this can be interleukin 12. Okay, but it can also be, right, it can also send some cytokines over that are interleukin 4. If it sends interleukin 4 over, it's going to turn this into a T helper 2 cell. And let's just say that we have some B cell here. And remember what I told you in the beginning, B cells can also bind antigens, right? So this B cell might have the same antigen that this antigen presenting cell had. And that can also bind to this T helper 2 cell. Okay, so when this happens, the B cell can also become activated. So the T cell is going to have a CD40 ligand receptor, and the B cell will have a CD40 receptor, okay? And this CD40 ligand binding is going to cause this B cell receptor carrying the antigen binding to this T cell receptor, right? It's going to cause this link up to eventually lead to this B cell undergoing class switching and potentially forming a plasma cell, potentially, okay, and undergoing class switching. And the thing that helps assist with this class switching process to go from a B cell that's primarily releasing IgM to a B cell that then releases some of these other antibodies with class switching is going to be this CD40 ligand linkage. And I'm getting a little off track because we'll talk about this in another video, but that's really this whole kind of process from start to finish. Again, started with an antigen presenting cell, sent interleukin 4 over to the T cell, caused it to become a T helper 2 cell. That T helper 2 cell can then run into a B cell that also is presenting this antigen. It can link up CD40 ligand and cause this B cell to develop class switching, IgG, which would be great for a memory response. If we wanted an IgE production, right, then the T helper 2 cell might release more interleukin 4 to this B cell. So it might send more interleukin 4 to the B cell. If it did that, we would get more IgE production. Okay, that would cause more IgE. Now, if instead the T cell sent interleukin 5, right, to this B cell, so let's just say instead it sent interleukin 5. So if it sent interleukin 5 to this B cell, then this B cell might produce IgA, for example. Okay, so that's where these interleukins come in. The initial interleukin 4 is largely driven by the antigen presenting cell sending it to this T cell, CD4 positive T cell, causing it to become T helper 2. This interleukin 4 is being sent to the B cell to cause that B cell to basically become a plasma cell, an antibody factory for IgE, right? As opposed to if we use interleukin 5, then becoming a factory for IgA. And interleukin 13 also has a similar effect to interleukin 4 in that it causes increases in IgE. Also remember, this sometimes gets looked over. IgG, which is probably the most common antibody that we talk about, also is coming from this interleukin 4 response, being sent to the B cell to switch, to class switch the heavy chain from IgM to IgG or IgE. Okay, so now if you're thinking about parasitic and allergic responses, it's also important to remember that interleukin 4, 5, 10, 13, 17, all very classic for those responses, which, I mean, it makes a lot of sense here. I mean, especially in an allergic response, right? You're thinking interleukin 4, interleukin 13. Why? Because IgE response, right? IgE is going to be very classic for the allergic responses in general. They're going to be binding to mast cells, for example, causing degranulation. And then interleukin 5, you might be saying, well, how is that related to an allergic response? Remember, interleukin 5 also causes upregulation of eosinophils. Okay, so eosinophils are also very classic in these responses. And you can also see that here, right? So interleukin 2, we already talked about it being kind of more nonspecific. The antigen presentation really driving this interaction to cause this naive CD4 positive T cell to go down to the T helper 2 route. So think of interleukin 4 kind of as the interleukin 12 equivalent of the T helper 2 response. Okay, and the last thing I want to talk about on here is going to be the Tregs and the T helper 17 response. And we're not going to go into too much detail on this. We're just talking high yield, high level overview. So think of TGF beta as the most high yield cytokine to remember when you're talking about a decrease in this immune response. If the immune response gets out of control, if it gets too high and you start attacking your own cells, you have some autoimmunity, the Tregs are essentially going to come in to control things, to get things to step down. And they're going to do that through the release of TGF beta. That's the most important cytokine to remember. The next most important will be interleukin 10. These are going to stimulate Treg development, which are essentially, like we said, going to prevent autoimmunity. You can imagine if you don't have these regulatory T cells or these Tregs, then you're at higher risk for autoimmune reactions because you don't have the cells that prevent autoimmunity, right? And then also this TGF beta will also be involved with the T helper 17 response, which is why I kind of include them here. T helper 17, it's pretty straightforward. It's going to classically be associated with interleukin 17, and these are mostly related to neutrophil function. We don't have to go into all the details on that. That's, pretty much the extent of it. So again, you can see here, TGF beta kind of being the classic molecule to remember when we're thinking about T helper 17 expression versus Tregs, but interleukin 10, much more specific for bringing down that immune response. And the way to really differentiate these two, again, interleukin 10 more associated with the kind of decreasing the immune response altogether, whereas when you're thinking about the T helper 17 response and neutrophils, you're thinking more about interleukin 17. And so that's kind of an easy way to distinguish both of these, even though they both involve TGF beta. Take 15 seconds to pause the video, read the question, and then we will go through the answer. All right, so we have a 74-year-old female presenting to the emergency department with acute onset diplopia and severe unilateral right-sided headaches. Her past medical history is significant for hypertension, hyperlipidemia, and osteopenia. The patient reports that she has had 10 pounds of weight loss over the past 3 months. Semi-concerning, especially in a 74-year-old, right? We might be thinking about potentially malignancy as a primary cause here, especially if it's unintentional. She has also had increased fatigue and symmetric bilateral shoulder, hip, and neck pain that is worse in the evening. Okay, that's interesting. Kind of sounds a little bit like polymyalgia rheumatica, right? This could be GCA. Let's keep reading here. Physical examination reveals a right temporal artery distension and tenderness to touch over the right temporal region. Okay, so, actually, let's re-highlight that this is actually a very important finding. So this, again, there's always certain things that you're going to see in these vignettes that are more important than others. This line right here pretty much to me, it kind of tells us exactly what we're dealing with. So when they start to talk about tenderness over the temporal artery or pain over the temporal artery or distension, especially in the setting of, double vision here and these unilateral right-sided headaches, it's very classic for giant cell arteritis. So I'm just going to put GCA, and this symmetric bilateral shoulder pain and hip pain is very classic for polymyalgia rheumatica. And these two are often kind of interlinked in board questions, especially in a older patient, usually a female patient in kind of the classic vignette style. All right, so let's kind of keep reading here. Laboratory evaluation reveals a significantly elevated ESR. All right, we talked about this before, ESR, CRP, they're kind of non-specific markers of inflammation. Now, usually if a patient has, GCA, the concern is that we don't want them to lose their vision, right? And so usually we start the steroids even before we confirm the diagnosis. So here, intravenous methylprednisolone is administered and her symptoms improve. Okay, great. 2 weeks later, the patient returns to the emergency department reporting worsening jaw claudication and visual loss in the right eye. Okay, so fundoscopic examination is shown below. We'll talk about this in a second. Urgent treatment with intravenous tocilizumab and methylprednisolone is initiated. Based on the vignette, which of the following are most likely inhibited by the pharmacologic management utilized in the treatment of this patient? If you take the time to memorize all of these different monoclonals, it would definitely pay some dividends here. The answer is interleukin 6. So tocilizumab is actually an interleukin 6 antagonist. So when you're talking about giant cell arteritis, what is exactly going on here? Well, the problem is you have this inflammatory reaction essentially happening here, right? You have this acute inflammatory reaction. And remember, when you have a lot of inflammation, right, you're talking about things like interleukin 1, interleukin 6, TNF alpha, right? These are all kind of your acute phase reactants, right? And so we've talked about this a couple times now. And, especially in the setting of this elevated erythrosedimentation rate, these are kind of all interlinked here. Now, if you give a patient, methylprednisolone, what are you trying to accomplish? Well, if you give a patient a steroid in general, if we kind of go back to the basics here, remember you have your PLA2, phospholipase A2, which eventually can turn into arachidonic acid. And this arachidonic acid can go down to form prostaglandins, right? It can go on to form leukotrienes like LTB4, which we've kind of talked about already. Glucocorticoids in general are going to kind of inhibit this process upstream here, right? So the methylprednisolone, the idea here is by inhibiting this, we're going to inhibit a lot of these pro-inflammatory downstream products that can be formed, okay? So that's what the methylprednisolone is doing. Tocilizumab is more specific to interleukin 6, which is actually pretty effective because interleukin 6 tends to rise very rapidly or fall very rapidly also. People that memorize tocilizumab might be rewarded here, but the point is, you can actually rule out a lot of the other options here. And let me kind of tell you what I mean by that. So if we look at option B, interleukin 10, right? Interleukin 10 and actually option D, transforming growth factor beta, both of these are actually going to be very much associated with anti-inflammatory reactions, right? So remember, interleukin 10 and TGF beta are both going to be more anti-inflammatory. So they're going to kind of attenuate the immune response, whereas interleukin 1, interleukin 6, TNF alpha, they're all going to be pro-inflammatory. So what are we trying to inhibit with our pharmacologic management? Are we trying to inhibit anti-inflammatory markers? No, we don't want to inhibit anti-inflammatory. We want anti-inflammatory because we're in the setting of an inflammatory state that's causing loss of vision, right? So we want to inhibit the things that are causing inflammation, like interleukin 6, for example. Okay, so these two you can pretty much rule out here. Receptor activator of nuclear factor, KB ligand. So this is just referring to rank L, okay? So you might be more familiar with it written as rank L, but again, you got to remember, you got to know what these things stand for, right? So rank L, remember, this is going to promote osteoclast activation. Osteoblasts are typically inhibited, right? And when we give patients things like methylprednisolone, right? Methylprednisolone, recall, can actually stimulate rank L to stimulate osteoclast to cause bone breakdown. So that's kind of a risk we take, even though this patient has osteopenia, but they have a much more, severe acute pathology where we would necessitate, steroids in this case. But remember, steroids can cause stimulation of rank L. So the fact that we're giving the patient steroids, we're not going to be necessarily inhibiting rank L. We actually, because we're giving glucocorticoids, we might actually be worsening the osteopenia or stimulating the rank L potentially, kind of as a side effect to the management of the GCA. Okay, the last one on here is alpha-4 integrin. Now this one, it's not as closely linked to a lot of the other things that we're talking about. The reason that this is a significant option here is because you have to know that alpha-4 integrin is very much associated with a very specific medication, and that medication is natalizumab. Okay, so I really want you to make sure you're familiar with natalizumab being the monoclonal antibody that targets alpha-4 integrin. Now, when would a patient use natalizumab? This is going to be very classic if a patient has like refractory or really, really bad multiple sclerosis. Okay, so it's usually not a first-line option, but in severe disease, it can be used in MS. Okay, natalizumab, the thing that you have to know about it, besides its use here and its target, is that very frequently when you put a patient on this, they're at risk of reactivation of the JC virus, right, which can cause PML. Okay, so this is a big thing to be familiar with. Again, similar to rituximab, you want to be familiar with that. But again, not directly linked to the target here. The target of tocilizumab is, again, to bring down the inflammatory response, targeting interleukin-6, an acute inflammatory reactant. Again, just be familiar, when you see this image, you see this kind of cherry red spot located right here, kind of surrounded by this pale area and discoloration of the retina back here. This cherry red spot is really at your fovea, and this is very, very classic for a central retinal artery occlusion. Okay, and we'll talk about more of this in another video, but central retinal artery occlusion, there's really three things that I want you to just kind of be familiar with. So the first one is carotid disease. So a patient that has, a carotid bruit, for example, these are the patients that are very classic to be at risk for having central retinal artery occlusion. The second one on here is a patient that has AFib, right? So they can throw emboli up to cause a central retinal artery occlusion, right? So you throw emboli up, right? You can have an emboli that goes to the kidneys, right? It can go to the brain, it can go to the central retinal artery. Okay, so that's the concept. And the third one on here is GCA. Okay, so you can get central retinal artery occlusion from GCA. Like we said, vision is something that we're hoping to maintain, which is why we give the steroids early to attenuate the inflammatory response. Remember, when you have a central retinal artery occlusion, this is classically described as kind of like a painless, sudden loss of vision, like a curtain's kind of coming over the eye. And again, we'll talk about more of this in another video, but I just wanted to make sure we kind of touched on that here. But again, the answer here, interleukin-6. Hey everybody, Dr. Viso here. In this video, we're going to talk about T cells. And so this is a pretty big video. We'll talk in the beginning about T cell development. What are the big things you have to know in regards to, how T cells develop, positive selection, negative selection. These tend to be particularly high yield. We'll talk a little bit about the MHC, or major histocompatibility complex 1 and 2. And then we'll talk about the process of T cell activation. If you've been following this video series so far, again, everything is really going to start here in the bone marrow. And we're going to have, CD34 positive hematopoietic stem cells that eventually form the myeloid and the lymphoid lineage. And we're primarily concerned, especially in immunology, with the lymphoid lineage. And this lymphoid lineage is going to give rise to T cells, to B cells, to natural killer cells. Now, the B cells, remember, the B cells are going to not only originate in the bone marrow, but they'll also then go on to kind of develop in the bone marrow. But the T cells are a little bit different. They'll also originate in the bone marrow because they all come from the lymphoid progenitor cells, right, which are going to be found in the bone marrow. However, the T cells are a little bit different in that they'll develop in an outside lymphoid organ, and that is going to be the thymus. And you might be saying, well, how do you even get these lymphoid progenitor cells over to the thymus? Well, there's certain chemokines that are released that essentially are going to signal the lymphoid progenitor cells to shuffle over some of their inventory over to the thymus so that we can develop some T cells. Okay, so this lymphoid progenitor cell is going to leave the bone marrow through the bloodstream and eventually go to the thymus. Okay, so that's what we have here. It leaves the bone marrow, goes to the thymus. And at this point, this cell is CD4 negative, CD8 negative. There's no CD4, there's no CD8 on this cell. And these are two markers you want to be really familiar with a T cell, particularly in the stages of development, because different stages, they'll